Hi everyone, and welcome to Webinar Wednesday. I'm your host Jessica King, and I just wanted to thank you all for joining us today. Prolapse, incontinence, and UTIs can be an uncomfortable conversation, but an even bigger inconvenience on your day-to-day life. Today's speaker, Urologist Dr. Benjamin Dillon, will go over some information about what could be going on down there for you. And a little more info on today's speaker. Dr. Dillon is board certified by the American Board of Urology in Female Pelvic Medicine and Reconstructive Surgery, or FMPRS. His clinical interests include incontinence, male and female, pelvic organ prolapse, voiding dysfunction, neurogenic bladder, pelvic floor reconstruction, BPH, and urodynamics. Did I say it right? Okay.
Correct.
And he joined Kelsey-Seybold in August of 2012, which means you're celebrating your 4-year anniversary with Kelsey.
That's right. Coming up on it.
Congratulations. Thank you. He practices at 4 Kelsey locations: Main Campus, Women's Center, Fort Bend Medical and Diagnostic Center, and the Spring Medical and Diagnostic Center. Don't forget, we'll be taking any questions you have at the end of the webinar. If one happens to pop up, just type it into your question box, and we will do our best to address it after Dr. Dillon's presentation.
Great. Thank you, Jessica. So we have a bunch of topics to go over today, and we'll go through them systematically, and then, as Jessica said, we'll have some questions at the end. The first topic we're going to talk about today is pelvic organ prolapse, which can be abbreviated as POP, and this is exclusively seen in my female population, and it's a condition whereby some of the organs in the female pelvis descend or drop, and that usually results as a result of weakened muscles, ligaments, and tissues in the pelvis. Typically we see the uterus drop, the bladder drop, or else a weakness on the back wall of the vagina, which causes the rectum to kind of protrude or herniate into the vagina or the vaginal canal. And today we'll talk about some of the causes, symptoms, and treatment options. So what are some of the common causes of pelvic organ prolapse? This is a common list, and certainly by no means an all-inclusive list, but commonly we see it in vaginal childbirth, particularly women who've had large birth weight babies, and women who've had multiple childbirths or even a traumatic or difficult vaginal delivery. Menopause is another common cause of pelvic floor issues, hormone levels, muscle weakness. As we all know, our body is dynamic and changes from the time we're a child until we die, and there's no constant state of our muscles and ligaments and tendons, and that's why things change and anatomic locations can alter. Some studies show that there's a genetic or familial component of pelvic organ prolapse, something which I really, other than mentioning that, I won't go into today. And certainly for the rectocele or the weakness of the back wall of the vagina, chronic constipation can be a contributing factor. What are the common symptoms that we see in pelvic organ prolapse? The biggest one is a pressure, pain, or fullness in the vagina. You may sense, or women may sense, a little ball protruding. Some women say it feels like a tennis ball or a golf ball, lemon, or a quote-unquote squishy feeling when I sit down. Some women may have urinary incontinence, which is a loss of urine, or paradoxically could even have urinary retention or difficulty emptying their bladder due to their degree of prolapse. As I mentioned earlier, chronic constipation can be a symptom of prolapse, and some women describe some vague lower back or abdominal pain too, with moderate to large prolapse.
Oh, you gotta click on it.
Okay. What are some treatment options? So, obviously, even though I'm a surgeon, I don't think every woman needs to be operated on. We certainly try non-conservative or non-aggressive, non-surgical options for our patients. We try conservative measures such as Kegel exercises, core strengthening exercises, support garments, something like a pessary, which is a rubber device that's inserted in the vagina. And our gynecologists are fantastic at helping women with some of the the pessaries or support garments. We do have several contracts with specialized type of physical therapists that can help on core strengthening exercises and Kegel exercises if a non-surgical option is appropriate and desired by a patient. Surgically, we have some treatment options. That's obviously the bulk of what I do as a surgeon, and there are several approaches that we can take to repair or fix a prolapse. I tend and favor somewhat of a transvaginal approach through the vagina. I do that for a number of reasons. One is it's a shorter surgery. I find it less invasive, and I think certainly outcomes in my particular hands are certainly as good, potentially some of the abdominal or robotic surgeries, which is the other option. Robotic surgery or abdominal assisted surgery is surgery that is done through small keyhole incisions. This is somewhat of a more complex, longer surgery, but for women with very severe prolapse, you might be an excellent candidate for that. Typically, the robotic surgery is done with the Da Vinci robotic system. The procedure itself technically is called a robotic sacral colpopexy and involves attaching a mesh to the top and the back wall of the vagina, and then we tack that back to the sacrum, which is the tailbone. It certainly is a favorable approach over traditional abdominal surgery. You make a large incision from the pubic bone to just underneath the belly button. It allows surgeon for better visualization, less blood loss, and again, if you are an appropriate candidate, it's a fantastic procedure. So that will about cover, a brief discussion. I know it was brief on urinary, on pelvic organ prolapse, and we're going to move on to urinary incontinence. Obviously, if there are questions about prolapse, please jot them down, and I'll be taking questions at the end of this discussion. So urinary incontinence is another big one. It is a multi-million, actually billion-dollar industry, and it affects about 25 million Americans throughout the country. Urinary incontinence is the involuntary leakage of urine, or we like to say loss of urine at a socially inappropriate and untimely manner. And it can result from loss of bladder control or loss of strength of the sphincter. Certainly urinary incontinence is somewhat more common in women, but it does occur in men. And there are two types of incontinence. There are actually three types, but two big ones, and then a third one is combined. So the two forms of incontinence are stress incontinence, and that's typically leakage that we see with cough, laugh, sneeze, picking up a grandchild or picking up a shopping bag, and you have the involuntary loss of urine. The other type of incontinence is urge incontinence, and that's typically associated with overactive bladder, urgency and frequency of urination. And then the third type of incontinence is actually a combination of the two. You have stress and urge, and that's called mixed incontinence. So stress incontinence, as I mentioned, is leakage of urine when someone coughs, laughs, or sneezes. It usually results from a weakened pelvic floor muscles, or even sometimes due to prolapse. Now, stress incontinence is more common, like I said, in women, but it can occur in men. Typically in men, this occurs in the setting of post-surgery, typically post-surgery for prostate cancer or some non-invasive treatments for benign enlargement of the prostate. But again, stress incontinence is much more common in our female population. Treatment options for stress incontinence, just real briefly, again, are in line with treatment options for pelvic organ prolapse. We have non-surgical treatment with pelvic floor muscle strengthening exercises. We have some office-based procedures that involve a bulking agent, and then we have slightly more invasive procedures that are sling procedures, be it a mesh sling. I know there are a lot of controversies about that, and also I do surgery where we can harvest some of your own tissue to make a sling out of that if there are concerns about the mesh complications, which is a whole different webinar in and of itself. Urge incontinence, again, as we talked about, can be related or fall under the umbrella of overactive bladder. Overactive bladder is actually a syndrome. It it involves urinary urgency, frequency, urge incontinence, and nocturia, or nighttime urination. But the actual urge incontinence, again, is a loss of urine associated with a sudden and uncontrollable urge to urinate. It usually stems from one of two causes, more commonly being idiopathic, meaning there's no source or no identifiable source of where it comes from. It could be from a nerve issue, a vascular issue, or a muscle issue. And then the other type of overact or urge incontinence can be associated with patients with neurologic conditions such as multiple sclerosis, Parkinson's, strokes, or less commonly seen neurodegenerative disorders. So a common question I get when speaking to friends or family is, well, when should you see your doctor about your incontinence? It is very common in women over the age of 40. It's definitely not part of the normal aging process, but we do see it quite commonly as people age. And the nice thing about what I do is, for me, incontinence is what I call quality of life medicine. Very, very, very rarely does anyone die from urinary incontinence. So this is really how the incontinence affects your quality of life. Is it affecting where you go, what you can wear, what activities you can do? And my answer to women when they ask me when should you talk to your doctor is, well, you should speak to someone when you're bothered by it. For some men or women who leak every day, they're not bothered by it, and for some men or women who leak on very few occasions, they're extremely bothered by it. So at any point you are bothered by it, I suggest you speak to someone. You're not necessarily committing to treatment, but you're just finding out what your options are, and I don't think that's something that in 2016 anybody should be bothered with or preoccupied, because there are lots of excellent treatment options. Again, some of the causes that we identified previously are age, past pregnancy, weight is a very big one, genetics, level of physical activity, and hormone status. What are treatment options? Again, we kind of glazed over some of these, but I'll go over them a little more in detail. And the big myth is that there's nothing that we can do about it. Again, that is completely a myth. We have a large variety of medications. 20 years ago, we had very few medications. Now we have many more, including some newer, more exciting medications that are a different type of class. Some medications are an option. As I mentioned, with stress incontinence, there are non-surgical options with behavioral management, pelvic floor physical therapy. We have in-office-based procedures for stress incontinence, as I mentioned, the bulking agents for overactive bladder. We have several, excellent and exciting treatments. We have two different types of nerve stimulation or neuromodulation that we use here at Kelsey-Seybold. And we do use Botox, which is a naturally existing chemotoxin or neurotoxin that helps paralyze the bladder, and some women and men have fantastic results with that. And as I mentioned, incontinence is more of an inconvenience than anything else. And again, it's up to the patient as to when they decide to seek treatment options. Urinary tract infections, that's another very common complaint I see for patients in my office. And this is really difficult because urinary tract infections are truly multifactorial, meaning that there can be many, many things that factor into urinary tract infection. So simply stated, a urinary tract infection is infection in any part of your urinary system, the kidneys, the ureters, the bladder, or the urethra. Most of the infections that we see typically involve the lower urinary tract, and that being the bladder and the urethra. Again, UTIs are very common, affect women, men, and children. 20% of women in the U.S. will develop a UTI, and of those, 20% will have a recurrence. And I think it's really important to stress, and there's a lot of emerging data from the American Urologic Association and Society of Urodynamics and Female Urogenital Surgery that show that just the mere presence of bacteria in the urine doesn't always have to be treated. And I think that's something that's, if you're going to take any message away from this webinar today, is I think you really grasp hold of that. And much like our bowel and our mouth have normal bacteria that populate it, That's not uncommon in the urinary tract too. And there is even some emerging data that shows that even the presence of normal flora in the urinary tract can be protective against future UTIs. So symptoms of recurrent urinary tract infections, again, some of these you'll see will cross over to what we talked about previously with overactive bladder, but a strong persistent urge to urinate. So for someone who typically doesn't have that, and then all of a sudden they do develop urinary urgency or frequency, then that may be a sign to say maybe I have a UTI. Burning when one urinates, again, this is kind of a tricky one because burning can be caused by a lot of things. A lot of people say, well, when they wake up in the morning and they urinate for the first time, they burn. That's not uncommon because your urine is most concentrated with all the toxins that your kidney gets out of your body, so that may burn a little bit. Passing frequent small amounts of urine, that's typically urinary frequency. That can be a symptom of urinary tract infection. Cloudy urine, again, is another symptom, although that isn't the only symptom. Urine that may appear discolored, that can be a sign of blood in the urine and certainly something more serious, but that too can be a foreshadow of a urinary tract infection. And then sometimes a strong smelling urine. Now, again, this is kind of a tricky one, somewhat reluctant to throw it out there, but everybody's urine smells differently. That can depend on what you eat, what you drink. So typically a real foul-smelling urine can be the sign of a urinary tract infection, but just a normal variation or deviant or deviation in what your urine smells like is not necessarily a strong indicator of a urinary tract infection. I do just want to say one thing, and this is, I'll throw in a personal bias. I am not a huge fan of the at-home self-diagnosis urinary tract kits that you can buy in the pharmacy. I think we have labs, and there are physicians here at Kelsey-Seybold that can help you. If you think you have a urinary tract infection, call someone, call your provider, call your urologist, and see if you can drop off a urine specimen. That's what everybody is here for and is trained for to do. Don't take that into your own hands to diagnose an infection, because often you'll see that when you do get one of those home kits, there are a lot of false positives that are picked up. So again, briefly we talked about this, but the various types of urinary tract infections. Kidney infection is acute pyelonephritis, upper, back, side, and flank pain, very high fever, shaking, chills, nausea, vomiting. The mere sign of a backache itself doesn't necessarily mean you have a urinary tract infection. Again, people who have kidney involvement of an infection are typically very sick, again with a high fever, shaking, chills, nausea, vomiting. More commonly we see cystitis, and that's pelvic pressure, lower abdominal discomfort, frequent painful urination, and occasionally blood in the urine. And then urethritis, which is a little less common, that can present with burning with urination and even some urethral discharge. Causes, so again, infection of the bladder, typically called cystitis. Most commonly this is seen by E. coli, is the most common urinary tract infection that we see. It's typically a bacteria that colonizes the gut. Again, this is part of the reason why women are more likely to get a urinary tract infection, because the distance between their anus and the urethra is shorter than in the male. But there are other common bugs that cause urinary tract infections. Infection of the urethra, again, this kind of comes in along with what I just mentioned about the short distance between the female urethra and the rectum. But that could also, urethritis can also be caused by sexually transmitted diseases such as gonorrhea, chlamydia, mycoplasma, so on and so forth. Treatment and prevention. So again, I think I made my point that treatment, really I stress that you let the treatment be handled by a medical professional and really don't try to take things into your own hand. One thing that you can do is when you do feel symptoms coming on, definitely push fluid. There isn't a whole lot of data on that shows that helps, but anecdotally, meaning from my experience and experience with my colleagues and partners, that definitely seems to help. Home remedies, I never tell someone not to do something other than, I think I probably just said not to do a home kit, but home remedies, I don't discount any homeopathic remedy. But my experience is if you do have a urinary tract infection, you really need an antibiotic and to have it properly diagnosed by a medical professional. When you do have a UTI, definitely try to avoid things that could irritate the lining of your bladder, which may be inflamed. Typically that's coffee, alcohol, and some carbonated beverages. You can use a heating pad, apply warm compresses, but again, if you're going to use that, use a heating pad with an automatic shut-off and don't fall asleep with the heating pad on you, because obviously that can have catastrophic effects. Cranberry juice, it's a common question, does that help? Yes, it does. Cranberry has a substance called proanthocyanidin that helps prevent UTIs. It helps prevent UTIs by preventing the bacteria from adhering to the wall of the vagina and the urethra and climbing up into the bladder. So that definitely works, but a common misconception is that if you drink a glass of cranberry juice, that's going to prevent it. The volume of cranberry juice that you need to drink is an extremely large amount, and there are several over-the-counter cranberry supplements, some that are better than others, that can give you the volume of PACs that you need to prevent urinary tract infections, and we here at Kelsey can give you the name of that if that's what it comes to. So I'm going to stop right there, and we have maybe about 5 minutes for questions. We have a few here, but if you want to type something in, we'll address them as they come up.
All right.
So for bladder infections, cranberry juice, is that okay? So I think, as I just mentioned, that is okay. I don't think it's going to hurt, but again, I think to really reap the benefits of cranberry, which essentially is PAC, I think you're better off to get a cranberry pill that has a fairly high concentration or milligrams of PACs. And by high, I mean you want to look for something that has at least a 20 milligram content of PACs. That's really what's going to help avoid those infections. Specific exercises that can help for urinary tract infections, really no specific exercises that can help prevent urinary tract infection. Great question. What could cause a person to keep getting recurrent UTIs? Well, the first thing is we need to make sure that these are truly recurrent UTIs. So recurrent UTI, and this is technical, but by definition, a recurrent UTI is a UTI where you are reinfected with the same bacteria every time. So if you are getting frequent infections, that means you're getting infections with different bacteria. So that question, there's kind of a long answer, but recurrent UTIs, it depends on activity. Are you emptying your bladder well? Are your infections, I think this came from a female, are your infections related to intercourse? Are you postmenopausal? Do you have any degree of prolapse? So all those are things that you should discuss with your primary care provider, gynecologist, or urologist to see why. First, are you getting recurrent urinary tract infections, and are you having any sort of anatomic or bladder reason to have the infections? Question from a male patient. I have to get up 2 to 3 times a night. Is there an over-counter medicine that I can try? So there really isn't. Nocturia, which is nighttime urination, is probably one of the most difficult things for urologists to treat, mainly because it's multifactorial. We know as men and women age, the volume of urine that they produce at night becomes greater once they hit a certain age threshold from when they were younger. And that can be due to cardiac issues, lung issues, sleep apnea, and so on and so forth. So the short answer is no, there's nothing over the counter that can help. The first thing I counsel most of my patients on is, much like we tell our children we're trying to potty train them, make sure you cut your fluids 2 to 3 hours before you go to bed. That's going to help. Make sure you empty your bladder. And then you also have to see, are you waking up truly because you have to pee, or are you being woken from other things and that's what's causing you to go to the bathroom? Question about slings and incontinence. If you already have a bladder sling and you still have incontinence, what should you do? So you should definitely speak to someone about that. The answer to that is not very clear-cut. So one of the things is that I speak to patients about who've been in that situation is what are your expectations? I'm not sure what you were told when you had your sling, but slings work well. They're not 100%. So if your incontinence is still better now than it was preoperatively, your surgery is considered a success. But there are still options that we have. As I mentioned in the presentation, we have some office-based procedures to kind of help bulk up the urethra and reduce leakage. There are physical therapy exercises that you can do, and there are other surgeries. But I think that's a very long discussion to have about what your expectations are, what your leakage is, what your type of leakage is. Is this a stress incontinence leakage, or is it now an overactive bladder urge incontinence in which a medication might be appropriate for you? The next question is another really good question. Any medical evidence showing sumo squats are almost better than Kegel exercises for pelvic muscles? I am not a pelvic floor physical therapist, and those who do pelvic floor physical therapy, I tip my hat to them. It's a very difficult, time-consuming job. Kegel exercises were kind of the gold standard for pelvic floor muscle exercises several years ago, but in the past 10 to 15 years we've seen that pelvic exercises can be as simple as Kegel exercises and can be almost 180 degrees where you want to do reverse Kegel exercises. So pelvic floor exercises can be increasing muscle tone or doing exercises to decrease muscle tone. So again, sumo squats may help, but that really is a better question geared towards a pelvic floor physical therapist, and that depends on which muscles you are trying to either strengthen or relax.
I actually have a question coming off of that one. Is it Kegel? I always pronounce it Kegel, so I've been doing it wrong.
Or maybe it's my New York accent.
So I know that's kind of prescribed to women, like try this, see if it helps. Can men also do Kegel exercises?
Absolutely. Men can definitely do Kegel exercises. So we find that men who are undergoing prostate surgery, they may benefit from doing Kegel exercises preoperatively and certainly doing it postoperatively. The one thing I'll say about Kegels for women is it used to be said just do Kegels whenever you're sitting at a traffic light, do Kegels whenever you have a commercial come on television. Now, pelvic floor physical therapists will tell us it's important to do Kegels during the times when you are more prone to leaking. So if you find that you leak every time you cough, well, if you feel a cough coming on as you cough, do a Kegel, or as you sneeze, do a Kegel, and that's going to do two things. One, it's going to trigger some muscle memory, and two, it's going to help strengthen those appropriate muscles during the times of that increased pressure. Does having babies put you at a greater or lesser risk of developing urinary problems compared to someone that has not given birth yet? Very good question. Certainly carrying a baby on your pelvic floor for 9 months definitely does put some strain on the female pelvis and does probably put you at a somewhat of a greater risk. But we do see plenty of women who have never had children, never carried children that do have urinary problems. But yes, the short answer is it is more common in women who have had babies in the past.
All right, I think we have time for one more question. I want to end us on something. Can weight loss or diet changes help improve urinary incontinence or any of these issues that happen in a woman's body or a man's body?
Absolutely. So weight loss is a big one. Most women, when they gain weight, tend to develop truncal obesity, and that's weight in their lower abdomen. That weight puts a lot of stress on the pelvic floor and the bladder. So particularly if a woman gets up, if she coughs or sneezes, all that kind of extra weight that they're carrying, is the force is going right onto the bladder. So weight loss has a significant impact on urinary incontinence, particularly stress incontinence. And a lot of times we'll see women that say, well, I developed stress incontinence, but I've also gained 20 or 30 pounds over the past year, and that has intimately tied into my incontinence. So yes, weight loss goes a long way in reducing incontinence, as does diet, as I mentioned, with caffeine, artificial sweeteners, and so on and so forth.
All right. Okay, so this is going to conclude our webinar today, and we hope the information that you learned today would be helpful to you in the future. I want to say a very big thank you to you, Dr. Dillon, for doing such a great job today, and of course thank you to all of y'all who joined us. Be sure to join us for our next webinar, An Apple a Day, 5 Ways to Get Kids to Eat Better, which is happening on September 7th by pediatrician Catherine Wright. And be sure to follow us on social media and join in on the conversation. Thanks again for tuning in, and we'll talk to you all next month.